welcome to the fourth webinar of the Early Career Members Network of the Metabolomics Society. My name is Evelina and I'm a postdoctoral fellow at the University of Cyprus, and I will be co-hosting this webinar with Alvaro, who's also a postdoctoral fellow at the University of Granada.
Hi everyone, and thanks for joining us again. I would like to inform you that all the material will be recorded and uploaded to the Metabolomics Society website, so you can have access to this live content at your own convenience. We would like also to encourage you to connect to our online social media networks via Facebook or Twitter for future content. Feel free also to mail us for future content or any suggestion for future speakers or topics for next webinars or other input. So we are delighted to host this webinar today about metabolomics applications based on gas chromatography. It's a pleasure for us to introduce Prof. Jeff Focant, who is a full professor at the chemistry department at the University of Leeds in Belgium. He's an expert in multidimensional GC coupled to MS. His team develops and validates analytical methods for the measurement of volatile molecules present in complex biological samples. His most recent activities are focused on breathomics, especially oriented to biomarker discovery in medical applications. Along with Prof. Jeff is Dr. Pierre, who is lead science and lecturer at Leeds University in Belgium. His main research interest is the development of analytical solutions based on chromatography and mass spectrometry technology. He has developed a strong expertise in multidimensional methods to increase resolution power. He is interested in the development of statistical models for method optimization and data handling. And he's working on the development of multimodal solution of untargeted screening of small molecules. So now I give to Evelyn.
Thanks, Alvaro.
Yeah. Okay.
Thank you, Alvaro. Our next webinar will be in September, but I'm sure you're all aware of the Metabolomics 2022 conference in Valencia. That will be in June. The EMN will have its workshop that will be on professional career development, and that will be on the 19th of June. So if you're interested, I highly encourage you guys to register to the workshop if you're attending the conference. But the EMN is also organizing a career night that will have different roundtables on different career topics, and as well as a job fair. And we will also have an EMN reception with a lot of surprises and prizes. So now I will give the lead to Professor Jeff. And thank you all for joining once again.
All right. Okay, I guess you guys now see the full screen. Just go. All right, so thanks for the invitation. That's the first time I participate to those webinars, so it's always a good new adventure to share. So thanks very much for the invitation. In the time I have today, I will basically make some sort of long introduction, and Pierre-Hugues, following this presentation, will go in a bit more details with some aspect of what I'm going to basically share with you now. As it was said in the introduction, I will mainly speak about what we call volatolomics, and using a specific tool, which is GC time-of-flight mass spectrometry, and I will go in a little bit more details in a minute about that. As you can see, there is quite a long list of authors on this presentation because it's not only, we are not only speaking about analytical chemistry here, we also involve a lot of colleagues from the hospital because they provide, of course, samples from their own patients, and they help us to make sense of the molecules that we could possibly isolate as potential biomarker in our studies. I'm just going to spend, like, let's say 5 minutes to introduce you to, for those of you who are not really familiar with GC-TOFMS, if I had to summarize what is GC-TOFMS compared to GC-TOFMS, for example, I'm going to use something that my colleague John Dimanja always used because he is one of the inventors of the technique. He says, when you move from GC to GC times GC, it's like when you move from black and white TV to color TV. If you only know black and white TV, you are happy with that. But if you know that, you know, color TV exists, you definitely want to go for color TV. So I think it's the same thing for GC times GC. To make a long story short, when we do GC times GC, instead of using one GC, one gas chromatography column, we use two columns which are connected in series. And in between those two columns, we put a piece of hardware we call the modulator. I will show you in a minute why we need a modulator. And at the end, there is only one detector. And in that case, in all of our application, we are using mass spectrometry, and we use time-of-flight mass spectrometry because it goes fast. You know, when you have a TOFMS, it goes very fast. And there is basically, when we speak about multi-dimensional GC, there is two main options. Either you, let's take this option first, either you go in GC-GC, I'm going to call it like this, where you do, you know, subsampling of what is getting out of the first dimension. You sample that, you put that aside, and then you know, selectively re-inject some fraction like you do in, you know, in what we call 2DLC when it's not comprehensive. But when you go for the comprehensive option, I would say, it means that everything that is getting out of the first dimension of your first GC column is also subject to the second dimension separation. So it's fully exhaustive. So that's why we call that comprehensive. And there is a, you know, times in between GC and GC because we multiply the peak capacity of the first dimension column by the peak capacity of the second dimension column, which means that your peak capacity, meaning the number of compounds that you can separate per unit of time, is really multiplied, you know, between those two columns, which is giving you a very high peak capacity. So if you go for this, let's say, comprehensive part, this is the type of picture that you will obtain. So instead of having a typical Gaussian-shaped type peaks, you know, that follow each other minutes after minutes, you have about the same thing on one axis, but then your Gaussian peak have been transformed into, you know, two-dimensional signals, which this is a reconstructed image. I will show you how we build that. But this is, you can see that every single, you know, glitch of color there is meaning that there is a peak behind. So you can imagine the number, we are speaking about a few hundreds of peaks here. This is a petroleum sample. And everything that would be on the, you know, on the vertical axis would have coeluted in normal 1D GC. So you can directly understand why we do this type of measurements. In practice, this is how it works. It's not a complex hardware. As always in GC or any type of chromatography, we have an injector. Then we have the first dimension column. Typically in GC, we speak about 30 meters column. That's the default size. Then we have this piece of hardware that I call the modulator. And then there is this second dimension. And then finally one detector. So again, there is only one detector in the setup of GC times GC. And you can see directly that the length of the second dimension column is shorter than the length of the first dimension, because everything we do in the second dimension has to go faster than what we do in the first dimension, because we want to be sure that we don't, you know, lose any separation that we would have gained in the first dimension by injecting in the second dimension. So if we speak about things going at the minute scale in the first dimension, it goes at the second scale. You know, it has to go faster, and then the mass spec go to the, you know, the millisecond scale even. So the time scale is very important, not to lose any resolution that we attain in the early dimension. And this modulator, you see, I've put a picture of like a butcher slicing machine there, because we could really compare the job of the modulator to a slicing machine, because things that are getting out of your first dimension, they enter that slicing machine, and the peak is getting cut in small pieces, refocused, and pushed into the second dimension for a second dimension separation. So that's the global idea. And just to make a long story short, and I will not go into those details, but this is how a modulator looks like. It's just something where you can see like this flat jet there. There is one jet, two jets, one slit, another slit. So there is what we call a quad jet modulator, which allows us to play as a slicing machine, basically. Or there is, and this is using cryofluids, I will tell you in a minute. Or there is also a few other options like valve modulation, but again, this is out of the scope of this presentation. So again, to make a long story short, and I know for those of you which are not familiar with the technique, it might be a bit too fast, but you know, I'm available for questions at the end if you want. But again, if you have your setup, imagine that at the end of your first dimension column, you have a peak, the black one here, that is actually a coeluting peak. So you don't know that because it looks like a nice Gaussian peak, but there is two peaks behind. There is the X peak and the Y peak. So if you enter that coeluting peak in the modulator as the slicing machine will do slices or subsampling of your large Gaussian peak. So it's a few, maybe 20-second peak width in the first dimension, and then you will start to make a first sample of the beginning of your peak, and you push that, you focus that in the second dimension, and you have a very short separation time of, let's say, 4 to 5 seconds, and then you reach the modulator. And the modulator will give you first a flat line, because there is nothing at that point. And then, let's say, 5 seconds later, you do another sampling. So the slicing machine does another slice. But then, for this slice, you start to have the blue compound, popping up at the end of the first dimension. So then when you push that in the second dimension, of course, you obtain a signal for the blue compound, which will have a certain retention time in the second dimension column. Then you do again 5 seconds later another slice. And at that point, you still, of course, have the blue compounds for which the intensity has been rising up. And you start to have a little bit of the red compound. So, of course, the blue compounds will again show up in your second dimension column at the same retention time than before. And now you also have another signal, the red one, at another retention time. And you basically solve the coelution. That's the idea, because the blue and the red are not coeluting anymore. And you do that, every 5 seconds for the entire time duration of the run. And you will see then that you are rising up in concentration or intensity with the blue compounds, then going down, and the same thing for the red compounds, and they are a little bit shifted one from each other. So, of course, your mass spectrometer doesn't know that you do GC times GC. So it will tell you, oh, you've got those nice, very short 5-second chromatogram. And then you need to feed that in a software in which you say, oh, by the way, all those blue signals, they only belong to one same molecule. So you need to recombine the signal, but at least you've been separating the red and the blue. So that's the idea of GC times GC. Then your software will recombine those slices, and you can, basically, if you put yourself on the top, you can have those, what we call the contour plots on the 2D planes, because there is the first dimension, or here, sorry, the first dimension and the second dimension retention time, and you have those two compounds which are now separated. So that's the idea behind. So at the end, the software can show you the peaks in different ways. Just taking a very simple example here. If we would have been doing normal 1D GC, this is what we would have obtained, the white trace there. Because we do GC times GC, it was many coelution, and we solved those coelution in the 2D plane. And this is, about 60 compounds there and maybe 100 compounds there. So it really helps for, of course, identification of the compounds. And again, if you put yourself on the top of this chromatogram, you will see those contour plots, which is another way to visualize, but this is basically doing the same thing. And there is another very interesting advantage. Because you do compression, I mean, the slicing machine is making a slice, but you also, before pushing it into the second dimension, you are compressing the peak, the slice that you created. And because of mass conservation, your Gaussian peak, because the slices are Gaussian as well, if you compress a Gaussian peak, and if the area under the peak has to remain the same, of course, the peak is going to be higher. And if the peak is higher, you can see it more easily. So you are improving your limit of detection or limit of quantification if you do quantification. So that's a very nice advantage as well of GC times GC, that the signals are higher, which give you more opportunities to find very low level signals or peaks or molecules, say it as you want. Just a quick picture here. This is the inside of a GC oven. I'm sure everyone has seen a GC oven before. So this, you've got the injector there. You've got the first dimension column, let's say 30 meter, and then it goes, there is a connector here, it goes into the modulator. The modulator is there behind. So this is where the magic happens, I would say. And then there is a small secondary oven, because remember, I want to go fast in the second dimension. So short column and also higher temperature. This is basic parameter of GC. And then the transfer line is there and the mass spec is on the side there. And I'm showing this because we do cryogenic modulation. Again, no time to go in details, but we use liquid nitrogen to make this, to create this slicing effect that we want. And the cherry on the cake is that behind this, as I said, we have a time of flight, which is a very fast acquisition mass spec system. So for this is just a couple of slices that I selected from what I showed you before. But for all of those slices, we've been very quickly acquiring data up to 500 hertz, for example. And then we have tons of mass spectra behind all those slices. And this is going to be part of the procedure for the software to recombine those two blue slices, because they would have obviously the same mass spectra, right? And the same retention time in the second dimension. So this is generating a lot of data, but it's very interesting because even if we take the example, if I go back to the same image of this peak that would have already been decoeluted, if I can say it like this, from the other peaks in this line, even though sometimes you still have coelution at the end, because you can be the best in choosing your two-dimension column, maybe one polar column, one less polar column. Some compounds will still have the exact same retention time on the two dimensions. So, GC-GC would not work. But because we have a time of flight and the deconvolution opportunity of the mass spec, because there is no mass queuing in a mass spec like time of flight, you could, deconvolute two different mass spectra even after still coelution in GC-GC. So that's really a powerful instrument, but there is a price to pay, always a price to pay. That, if for a classical 45-minute run, for example, let's say 200 hertz, a mass range that goes up to 400, we are looking mainly to volatile or low molecular weight molecules here. This is the number of data points that you will get. So when you have a few hundred, of millions of data points, data processing becomes a challenge. So we will have to consider that in what we do. But at least there is enough motivation for us to use it and try to get better description of complex samples. Just to also have a little bit of a look in the history. In 1991 was the year of the invention of GC times GC. And you can see, as always, when you have new technologies, sorry, nothing much happened in the first few years. But then the petroleum industry, because the first users have been the petroleum industry for GC times GC, because crude oil is very complex. Then, the interest in light blue, this is the number of GC-GC papers every year. And you can see that, it has been about 2,300 papers up to now. This was updated like months ago. And most of those GC-GC are done, those GC-GC experiments are done. This is the red trace with MS as a detection device. When it's not MS, is for example, flame ionization detection, which is also very good, but it's non-specific detector. And if you look to the green trace, this is the proportion of TOF inside the mass spec usage. So you can see that, let's say, 2/3 of the mass spectrometry that is used with GC-GC is time of flight. So the reason I mentioned earlier that it goes very fast. So that's important. And then it's also a little bit of fast scanning quadrupole that now are also available on the market. And this is interesting also to see that, the little signal down there is GC-GC high resolution time of flight mass spectrometry. When it first appeared on the market, we were all like, oh, so excited. It's going to, go be exponentially rising. And you can see it's not the case. And the reason, remember, few hundreds of millions of data points. So because of the difficulties of data processing, this is why it's still quite limited. So many in metabolomics, but also in other applications, many people are still using GC-GC low resolution TOFMS and only shifting to high resolution TOFMS when you have your biomarker that have been selected and you go for the final identification with high res. But you don't want to use high res all the time because it's really a nightmare to process the data. And then if you look to metabolomics itself, I mean, it's also quite young, if you look to the literature, this is from Scopus, and, it has been a few thousand papers, speaking about metabolomics for the last few years. And if you look at the proportion of the metabolomics that is done by gas chromatography, it's about, a bit less than 10%. And if you look to GC times GC in metabolomics, it's less than 0.3%. So it's quite surprising because I'm just trying to sell you a very good, technology. Wow, look at all what you can do, and only 0.3% of the metabolomics is done by GC times GC. And again, keep in mind that data processing nowadays is still quite complex, although we are moving in the good direction there. So that's basically for the introduction of the technology. And again, remember, the idea behind it that we have 2 retention time instead of 1 with classical GC or classical LC, 2 retention times. We've got also possibilities to work on Kendrick mass defect, but it's a bit out of the scope for metabolomics. But we have accurate mass, so we can build basically molecular formula. And when you are playing with small molecules, when you have a good molecular formula with a mass accuracy of, let's say, 1 ppm, there is only 1 possible formula, which is very interesting for identification. We can work on electron impact. We can work on software ionization to be sure that we have the parent ion. And also, an interesting aspect of GC times GC is that we are creating images. So when we have, for example, to compare sets of patients suffering from a pathology versus controls, you have all the information about retention time, mass spectra, blah, blah, blah. But you also have images that you could just compare image versus image, which also could be very interesting to do. And we are trying also to do that. So in metabolomics, it's interesting because we have a quite good level of identification. I will come back to that a bit later. So all those are the reasons why we do GC times GC. In any case, when we want to do medical application or most of the separation science application, we could basically divide it in 3 main steps. Of course, as always in analytical chemistry, we have to sample, and this is a crucial step because if your sample is not good, you're just wasting your time. Then you need to optimize your separation. Even though we do GC times GC, we spend a lot of time to optimize our separation. And then at the end, we have to spend time on the data treatment. About something, especially if you go for medical application, we want it to be efficient as always, but we also want it to be, of low level of invasiveness, because when you have to go to your patient and say, okay, I need 500 milliliters of blood, or I need a piece of your lung, I mean, they're not really jumping to the sky. So you need to be using matrices which are not too much invasive. You have to use devices that are, let's say, user-friendly, like a Tedlar bag. For those of you who knows, those plastic bags, this is what I call user-friendly because you just blow up. Everybody has been blowing a bag in his life, so that's not new for the patient. And then, as I say, you have to go for the separation and the detection. So we're speaking about GC-TOFMS. So we optimize GC-GC. We optimize also the sampling part if we use different type of trapping devices, for example. And we need to optimize it to help us to identify the features when we will do a data treatment. Again, the quality of our chromatography is really important for the data treatment, because if you have bad chromatography, you have bad data treatment. And then you have all the tools, we'll speak about that earlier. The tools that we use and the sample that we use, it can be very invasive, bronchoscopy, it can be sample that are taken from the hospital staff, like bronchoalveolar lavages. Pierre-Hugues will speak about that later. So we don't do that especially for us, but when we have access to this is very useful. The breath of the patient, the blood, the urine, the feces, typical biological samples. So I'm going to just speak about 2 major areas of application here. The first one is more on the digestive system, on Crohn's disease. Maybe you're not aware or not familiar with that pathology, but that's something which is quite high prevalent. It's an inflammation of the digestive system, and it's still a lot of things that are not really properly understood. So, having any biomarker is interesting, not only for screening, but also for understanding the pathology. So we did a study, which was more feasibility study. So we had like 70 samples, and we implemented a very high level of QA/QC because this is something which is critical. The good news was, because I was on blood and serum, is that there is some reference material there, and we spend a lot of time on optimizing everything in terms of very high quality analytical chemistry. And we did a lot of QA/QC. Again, I will not go too much in detail because Pierre-Hugues will speak also about that, but in our procedure, it's always a multi-step procedure where we have to create those images by optimizing, the GC, the mass spec, the way we sample, the sample collection itself. And once we got that, we get those, many images that we create what we call an average or composite image, including all the compounds, and then we compare image by image to see the differences in between samples. We have to, of course, align all those chromatograms, which sometimes can be challenging. We need to do then data reduction to finally, at the end, do the data processing. So it's many, many steps that needs to be considered to end up with a potential list of molecules of interest, or let's say biomarkers. And just to be sure that you understand the importance of the what we call the data science there, because I'm a chemist, but look, this is the part that's really the chemistry here, and the rest there, the remaining part of the procedure is just data. Or I should not say just, because this is the main part, but this is data processing. So we spend some time in optimization for the separation science, but we have also to spend a lot of time implementing QA/QC, implementing pre-treatment method to make our matrices of data suitable for the statistical treatment that we want to apply. Either if we go, univariate, multivariate, supervised, unsupervised, we need to very well polish and prepare the data set before we even think about this. So that's a very important step. If you want more details, we get this review type paper that was published last year, which we try to give guidelines in the field on how to prepare the data for treatment. So a few pictures now just to show you how it works for the Crohn's disease study that we did. So for that study, we had patients that were, let's say the control, the healthy patient, the highly inflamed patient, the low inflammation, and the patient that were in remission. And you can see that there are some trends that typical PCA treatment, or on PLS also with this expert, we were able to isolate some of those compounds of interest. And also we isolated by basically 16 biomarkers. And that was interesting also for us to look what were the retention time. This is the GC plot. What were the retention time of those biomarkers? Because it could also be a piece of information, because we know about the polarity of the GC phases, for example. That could be a piece of information that would be interesting to see where they pop up in the chromatogram, because we could say, oh, maybe the down-regulated or the up-regulated biomarker are more or less polar, for example, which is an interesting information to also collect. But I don't have, again, time to go in details in that direction today. But keep in mind that because we have images, we have also an extra piece of information. Typical data treatment, this dendrogram, definitely it appeared that the patient in remission and the patient that were highly inflamed, they had still, biomarkers that were similar. So, when people are in remission, they are still showing signs of, of the illness, I would say. And the patient that were very low and the healthy patient were also basically getting together in those statistical treatment. The prediction with the ROC curve, you can see that the prediction capability was quite good for those samples. We, of course, we compare that with all the confounding factors that we had, and you can see that for one biomarker that I will call X15 here, differences between the healthy and the low and the other group, and it was not related to gender, and the same thing for some other biomarker there. So again, I don't have time here to show you all details, but we pay attention to all the confounding factors that could bias what we do. But at the end, we were basically selecting those biomarkers. And if inside the population that we had, we only focus on the healthy and the high, so I would say the extreme of the patient, you can really see that, quite high level of the variance can be explained here, and definitely separating those two classes of sample, I would say. So again, very promising. It's giving, it's feeding the research in the field, and the colleagues trying to better understand the illness are very happy to have those type of information, because of course the next step is to go biologically to try to see, okay, what does that mean? What did those chemicals mean in terms of the pathology? That was the first example on blood. Another example here on breast. And this is Linus Pauling, you know that guy, and he was probably the first to speak about breathomics, I would call it like this. And I'm going to show you an example on asthma and on systemic sclerosis, again using GC-TOFMS. All those, I'll call that lung-related diseases, and again, Pierre-Hugues will speak a bit in more details later today. We try to, to do those samples using, as I mentioned earlier, Tedlar bags. There are pros and contrasts for Tedlar bags because, it's a chemical polymer, so it's bleeding also, but we know those compounds which are bleeding, so we can remove them from the chromatogram. But this is a very, what I call, user-friendly way to do sampling. Once the patient has been filling the bag, we transfer that to thermal destruction tubes, we put that on the GC injector, and we start the procedure. So that's the global idea. And we first considered asthma because I don't know if you are aware of that, because I was not before doing the study, but very difficult to phenotype the asthma. So if you are diagnosed with asthma, the next step is to decide or to find which phenotype of asthma you are suffering. And most of the time it's difficult and people get under medication, but it's not a good medication because the phenotyping was not efficient. So again, same thing, we need biomarkers there. To make a long story short, it was a study in 2 steps. The first step was done with the colleagues at the University of Maastricht in the Netherlands, 276 patients, and they end up with 7 biomarkers. And then in Liège, we did a parallel study with a bit less sample, new patients basically, and we were able to, completely independently with GC-TOFMS to confirm 5 of those biomarkers. And if you look to the names of those biomarkers, you might just say, oh, this is so simple molecules. I mean, this is just really hexane, androgen, nonanal, which is coming very often in our measurement, propanol, hexanone. So quite, I would say, very simple molecules which were selected as biomarker and validated with those 2 studies. And just to also highlight the usefulness of those biomarkers, those VOCs, nowadays in hospital, to try to phenotype the asthma, the medical staff is measuring the nitric oxide in the breath of the patient. And this is, in this rock curve, this is the blue line, so you can see the area under the curve. It's not too bad, but it could be better. Also, in some hospitals, they measure the eosinophilic count in blood, which in that case is the red line, so it's performing similarly to the pheno. And then when we were doing the VOC, on those 5 biomarkers, it was also similar performances. But the interesting point here is that if we combine those 3 different approaches, which are quite orthogonal because the level of nitric oxide is not related to VOCs, not directly related to VOCs, the eosinophil count either. So we would have the green line on this rock curve, so increasing significantly the area under the curve. So just to tell you that combining the different approaches is very useful there. And again, there is the reference of the paper there in the blue journal where you can find more information. The last example is systemic sclerosis. To make a long story short, this is a fibrosis problem. It can happen on different parts of your body, but sometimes it also happens in your lung. And then it's called interstitial lung disease. So basically, it reduces significantly your respiratory capacity. So it can really be a very important problem. And it's very difficult to early diagnose. So anything that can be done to help diagnosis and also prognosis, and try to follow up the patient and maybe help for personal medication or going in that direction is good to take. And the idea was again to try to see, can we measure something in the breath of the patient? Because it's of course a very low level of invasiveness. And this time I want to show you chromatogram because on the left part, this is the healthy subject, and on the right part, those are the SSC patient, and you can directly visually see that there is a very big difference in between the 2. So it seems to be much more compounds, and this is paired samples, much more compounds in the systemic sclerosis patient than in the reference patient. So not too difficult to highlight and to spot that certain families of compounds, and you can see that there is quite a large range of families of compounds, are present. Most of them, it's increase of those compounds, as we saw in the chromatogram, in the SSC patient. So again, those can be found, separated, identified, and confirmed as biomarkers. In this case, for the SSC patient, it was a small cohort. Again, that was a proof of concept, 30 and 30. So at the beginning, we had what we call 500 features. We could say 500 peaks, but among those peaks, some signals are artifact or not of interest. So first we need to polish it a little bit. So we remove, let's say, 150 compounds, and then we can even go deeper to start to, the processing to really try to focus on the compounds of interest, and then to apply, let's say, in that case, different ways of multivariate statistics, which are very often used in metabolomics, and try to, at the end, isolate a reduced number of biomarkers there. And then using those biomarkers, you look to your compounds, to your sample, and this is the list of those biomarkers with, we've got an exact mass, we've got 2 retention time, we can do standard injection for confirmation. So we really go, higher in level of confidence and identification, I would say. And this is how it looks again. If you look, 50% of the variants there, 14 there, we can really see that there is a difference, right, in between the controls and the ILD patients. That's definitely working. Again, the curve is saying the same thing. So there is a potential. There is no doubt that there is a potential that measuring the breadth of ILD patient would help to differentiate them from the people which are not suffering from the pathology. We could say, yeah, but you are lucky, this is pure luck, and maybe those 16 biomarkers are not specific. So let's take any 16 other molecule among the 73 I was mentioning earlier. The model would completely collapse. So this is not just luck or chance that those 16 biomarkers that we selected can differentiate between the two, the ILD and the controls. When you randomly select the compounds, it's not working anymore. We also included the smoking habits, the medical treatment that was potentially given to the patient, like corticosteroids are the main ones, and immunosuppressors. And again, the model completely collapsed if you look to those confounding factors. So I think it's really demonstrating that what we measure in the breast of those patients can really drive us to selection of some biomarker of interest for diagnosis, at least for diagnosis. And then the next step, of course, is to go to and follow up those patients to see how it evolves over time. So first quick conclusion, and then I will just give you a few more slides to complete the presentation. But I think we should agree that GC, and I put high-res in brackets because, as I explained earlier, we don't have to do everything in high-res first, just for identity confirmation. It's metabolomics, of course, not metabolomics. And breastomics, it's definitely has a potential. We still have to do quite a significant amount of manual data treatment because of the complexity of the data, but it's really changing every month. It's getting better. We need, of course, to apply supervised statistics. That's no wonder about that. And we really think that, if we look to the technology readiness level scale, we really, very slowly, but we are moving up in that scale. And hopefully, the move is going to be exponential because of the very nice improvement of the tools that we use. And probably, and I will finish with those a couple of slides, what is also very much missing right now in breastomics, and I think generally in metabolomics, although it's going in good direction, but QA/QC has been overlooked, by many people, let's say it like this, for many times because of the lack of standardization. And I think any initiative like the MSI from 2007 is probably the major one, which is absolutely perfect and very useful for the people in the field. Anything that can be done to increase the robustness of what we do will enhance our impact in the medical world, because very often you go to the medical world and you say, oh, I can do something with the breast of the patient. They say, yeah, sure. I mean, 15 years ago, we heard about that already, but there is very few usage in the hospital because of the lack of reproducibility. Even though I would prepare a set of data in my lab and I would send it in another GC lab, depending on the way we're going to process the data, we might end up with different biomarkers. This is not normal. So this is something we have to fight against. So that's, as I mentioned earlier, we do a lot of QA/QC. We monitor how the system is evolving over time, because when you have a cohort of 1,000 samples, you don't do that in one day. It might spread over a few weeks. And then in the meantime, you might have to change your GC column. You might have to, recalibrate your mass specs. So it will impact your data. So you need to document that and to maybe apply correction factors, for example, to be sure that you really don't bias your data. That's important. There are some other initiatives, the peppermint experiment, for those of you who are maybe interested in breathomics. It's not really an intercalibration exercise, but at least it's a multi-lab exercise to try to better understand how the compounds are released by the lung and try to normalize, the sampling, for example. A very important initiative. The NIST is also, I mentioned the NIST certified reference material or standard reference material on blood earlier for metabolomics. One is under development also for feces, and we participated to a study where we were comparing, the impact of lyophilization on the feces, the impact of the type of food, like if you go for omnivore versus vegan, for example, to try to develop as the best as we can this reference material. Also very important to have access to those reference material. So at the end, and this would be my conclusion side, we have a technology which is, yes, of course, complex, not too expensive. Honestly, it's not too expensive, but it's complex because it's generating so much data, and we just probably touched the tip of the iceberg by looking to the data that we look at. But still, there is a lot of data behind that can also be exploited later on if we want. Again, the visualization aspect is important. And that was the last part I just showed you. We need more robustness. We need more reproducibility. And then it will definitely help to move, from the lab to the hospital. And that's why we do this. That was the idea of this presentation, to tell you why do we do GC-TOFMS in metabolomics, and these are the reason why. As I said at the beginning, many people involved. I really want to thank all those guys. I'm a very lucky, head of service here because I've got many very good people in my lab. So I really want to thank them and all the collaborators for helping us financially also to develop those methods. So I will stop here. I thank you for being here today, and you will see that Pierre-Hugues will really continue on that presentation with his presentation. So thank you very much.
Thank you, Pierre. Thank you for the really nice presentation. I will give the stage to Pierre. And while Pierre is sharing his presentation, I would like to remind everyone to pop their questions in the question box. And please make sure you mention to whom you're referring the question to. And thanks, and Pierre, the stage is yours.
Thank you for the introduction, and thanks, Jeff, for setting up the floor for me and letting me present more applied research on metabolomics. So today I will speak about our research that we are doing, speaking about specifically lung inflammation, and for me, it's the second time presenting a webinar for the EMN webinar series, and it's really interesting because I went back to the slide that I was presenting 2 years ago in 2019 as a postdoc, just moving in the University of Liège, and the topic was can we really use GC for metabolomics, and what are the challenges? And what Jeff has shown you today, and what I want to show you today too, is the fact that yes, there is progress, and yes, it's still a method that has a future in the field. So I want to start my presentation today taking back the conclusion from 2 years ago, and I was closing my webinar with this quote from Ronald Fisher, so a famous statistician, that was saying that to consult a statistician after an experiment is finished, it's often merely to ask him to do a post-mortem examination. And I think this is this whole idea to have a proper study design and a robust analytical workflow that is required for the pursuit of untargeted metabolomics. So what is the situation in 2022? And I will use the introduction that Jeff done on the breast research that we have been conducting in inflammatory disease, and see from how breast analysis push us to do more fundamental metabolomics. So this is the slide that Jeff just showed you about like the breast print study where we try to phenotype asthma, and the 5 compounds that we validated, so that we are really sure that they were there. So for us, it was a big achievement, and we wanted to build on that success. And the question was where these biomarkers are coming from. So when we are talking with the clinical team, they say, okay, we have markers that allow us to have a better decision in the clinic. But the question is, if we understand where they are coming from, maybe we can also use this information for better treatment or better approaches in the disease management. So when you dive into the breast research world and you ask someone like, oh, where this compound is coming from, you have like 99% of chance they will say, oh, you know, it's coming from oxidative stress. So it's kind of the go-to answer, because oxidative stress is kind of explaining everything around inflammation. So we started there and trying to understand what exactly it's inside this oxidative stress. So oxidative stress, it's an inflammatory response that is due to almost anything happening to your body, environmental factor. So I don't know how it is in your country today, but in Belgium we have a really nice spring that is quite dry. So we have a lot of pollen. So for someone that is allergic like me, I'm having like a really high reaction to that and some inflammation too. So the environment has an effect on that with the pollution, but also natural effect like allergy. And it's linked to also metabolism perturbation. So you can have a metabolic disease that increase the inflammatory response of your body, and so created more oxidative stress. And it's all regulated by the cytokine activity. So we know that all the chronic inflammatory disease that we study, like asthma, they are linked to any type of cytokine like EL5 or IL6. So we know that they are impacting the metabolism, but we don't know what are the small molecules that result from this impact on the metabolism. So going down the line of the metabolic pathway, we start studying which type of molecule could be generating the compounds that we see in the breast. And the most probable way, it's the lipid peroxidation. So oxidative stress that is caused by plenty of things, create reactive oxygen species, and this species can react with different type of lipids that can be fatty acid, that can be triglyceride, and generate small molecules that are primarily hydrocarbons, aldehyde, ketone, and alcohol. So the compounds that we see in the breast, and the family of compounds that are the biomarker of asthma phenotype that we use. So we had a lead to start for our investigation. So if you want to identify really the origin of this marker, is where the big metabolomics and omics in general power need to enter in the game, because we need to understand what's happening on the lipidome level, the proteome level, and the small molecule, and even like some transcriptomic information. So we need all this information, and just for the molecular size, from big proteins to small molecule, we need different instrumentation. So this is really like what we are trying to do, try to have a convergent omics approach to understand this question. But today we speak about GC-GC, so I will mostly focus on the small molecule. And coming back to my opening with the need of analytical workflow, what we have been doing during the last 3 years for this question about what can we do about our understanding of lung inflammation, we develop unoptimized workflow for GC-TOFMS that can be applied to mostly all type of samples. So we have a breast protocol that Jeff presented you just before, and for all the other lung matrices, so ex vivo fluids like bronchoalveolar lavage, blood bronchial aspirate, sputum sample, or even in vitro sample like cell media or cell content, we have a single GC-GC run that is compatible with everything. And it's maybe not the best for all the matrices, but because it's worked for all type of matrices pretty decently, that means that we can compare the data more easily, and we can really, like, from one study to another, see what's changing and try to compare different disease or different sample set that we have. So this is really important thing for us to have a kind of a routine system that it's easily monitored by QA/QC system, but it also allows us to have a higher throughput on the injection side. So this is the system that we use. So for volatile, we use solid phase microextraction, SPME. We developed the method to try to use 500 microliters, so a small quantity for this type of study, because when you have BAL sample, it's sometimes like only a few milliliters, so we don't want to use everything. We need to share with other techniques, so that's why we go for miniaturized sample, and we try to go even smaller than that. And we have a common GC-GC condition that is compatible with everything. And after the data processing, and as Jeff said, now that we have this optimized analytical condition, we are mostly working on the, I would say, routine workflow for the data processing. And when we wanted to start that, we kind of approach the data processing as we approach the analytical methods. So we would try to see which steps in the analytical, in the data processing workflow has the bigger impact on the result, which are the part where the user impact is really high and where we have to make sure that we control exactly what's happening. And this is how we develop this tool that we use, we call the user impact gauge, where we see that, okay, if I ask several people in the group to process the same data, where is the decision-making process that has the most impact on the resulting model or a data structure. And to do that, we went through all the steps, and we every time had what we call a data quality check. So for GC-GC, we have a lot of dimensions. So it was mostly using visualization tool like PCA to try to see, okay, if I make that decision, how is it affecting the dispersion of my sample set in a space containing from 2 to 5 principal components, just to see, like, is the dispersion affected, yes or no, and how it's affected. And doing that, we were allowed to control the steps that are really important in the data processing to improve repeatability in the processing. So the first really high impact zone was the alignment, where we have to align all the data to create a single data set. So it's where, like, the criteria of matching the chromatogram and how we allow compounds to be, like, compare from one sample to another. What is the allow shift on the retention time? What is the allow shift on the mass spec? That really impacts. So now we are trying to have a lab-based SOP, and working with the GC-GC community, we try to, like, bring that SOP to the field level and not just the lab level. And same for the model validation. So like with GC-GC, like, you have a lot of features, so it's really easy to overfit. So the way that we select features and the way that we will use this dimensionality in the validation step is really important too. So today I will present you 2 of the applications using this optimized GC-GC workflow for different matrices. The first one is bronchoalveolar lavage fluids that were coming from lung transplant patient to try to better understand primary graft dysfunction. And after, I want to show you our first steps in the development of in vitro asthma model that allow us to mimic inflammatory mechanism in vitro to try to use this model for our multi-omics approach. So the first step, so the first study was this investigation on PGD, so primary graft dysfunction. And primary graft dysfunction is the major cause of death in the first 3 days after transplant. So when you have a big organ failure just after transplant, it's mostly PGD generating that. So it's a multifactorial condition that is generating a big inflammatory response in the body that usually is linked to organ dysfunction and transplant failure. So we wanted to have some clinical marker of this PGD, see if we can predict if it will be developed or not, or try to understand what are the molecular mechanisms to see if we can prevent PGD development. So we had two sets of data. We had bronchoalveolar lavage. So a lavage is really like saline solution injected deep in your lungs, so on the alveolar level, and aspirate back through a bronchoscope. So you really have the content of the alveol. So it's really what is used for microbiological plating, really to see if you have an infection there. And we use also a blunt bronchial aspirate, so it's upper in the respiratory tract, so it's at the beginning of your bronchus. So it's mostly like aspiration of the fluids when you are intubated. So it's less specific, but it's less invasive. So we wanted to see the two matrices and how they compare to each other. So this is the study population, so 40 patients. So we may say, okay, 40 is not a lot, but when you know that your selection criteria is double lung transplant in one center, that's a lot of patients. So that's a multi-year project to reach that number. So, and the sample were collected at Bronton Hartfield Hospital in London. So I want to acknowledge the medical team that did impressive work by recruiting the patient for this study. So the first thing that we had to deal with is the fact that to reach this 40, it was over like several years of sample collection. So of course, the process in the operating room is changing over time. So of course, we had some shifting, but because we had a QC system for the sampling and on the system, that allow us to really like take that into account and change the structure of the data. So you can see on the left that, again, using PCA as data quality check, I have two groups, so because of the two process, but we were allowed to correct this sample and bring everything at the center before to start the processing. So we took the sample, so 500 microliters, we put it on the system with our optimized workflow. I will skip all the pre-processing step, and after we arrive to the model building. And what's really interesting, it's when we did the study, there was like nothing out there about machine learning for GC data. And so we had to develop our own selection criteria to try to choose the best way to approach the data. So again, we approach it like step by step with an analytical chemist eye by comparing like the different cross-validation, the model, the different machine learning approach and non-machine learning like regression model to try to see what was the best working for us. And our question was like, can we identify severe PGD versus non-severe or non-PGD patient? So our two criteria of selection was the accuracy of the model at the end and the stability. So we did a pre-screening of all these methods, and we finally select leave one out cross-validation during the model building with a support vector machine. So again, that's to show the process of everything is kind of an iteration to try to get the best of our data and our sample because we could not waste the sample. So when you had this first screening and you know the way you want to go for the data processing workflow, after you can build something that it's nice and efficient. So we had our setup criteria for the data collection, the alignment and the pre-processing that were like based on our SOP. And after we split the data, we build a model and we implement like different layers of cross-validation to really like specifically make sure that we were ruling out a lot of variation from the samples. So this was the result. So you have a ROC curve. I on purpose put the confidence interval on the ROC curve because it's huge, but it's just because the population is highly diverse. So when you have a lung transplant, the reason for the lung transplant can be highly different. Maybe you had a chronic disease like cystic fibrosis, or maybe you had a cancer because you were smoking. So that means that you are like in really two different stage of your life and under two different treatments. So we have this big variability, and until we can build a multi-center approach to try to have a huge number of samples, we will always have to deal with this variability. But something that was the most interesting for us was not the accuracy of the model or the confusion matrix that we obtained, it's the classification probability. So to give you a bit of context, PGD, it's classified into grades. So if you are PGD 0, that means that you don't have any PGD, so it's good for you. And if you are PGD 3, that means that you have a highly inflammatory response, so and like the prognostic is not good. So in our model, what we discover is basically that if we build a model trying to differentiate low PGD and severe PGD, the classification probability of the model is correlating with the grade that is defined by the clinician. So to define the grade, the gold standard, it's a clinical team taking into account plenty of clinical information. So imaging information, blood analysis, status of the patient, infection report. So they have to take a decision and grade you. So it's a human decision. But if we look to the chemical decision that we are doing, we see that most of the misclassified compounds, so the dots with a hole inside, the empty dots here, they were PGD2. So when we discuss with the clinical team, they say it's interesting because between PGD2 and PGD3, the border is really thin. So maybe it's people that are in the same molecular status than PGD3, but just because there were no infection or no fever, they are not classified as PGD3. So the fact that our misclassified individuals were mostly PGD2 means that maybe the system is really like following the inflammatory level in the lung. So that was really promising for us. So of course, again, like to insist on the fact that when you build a data processing workflow, you need to implement the cross-validation. So we did like a random feature selection, random labeling of the sample. We also tried to build a model with all the features that we detect in the sample, and you see that only the well-designed model was performing here. And a criteria that we always have also when we are building model is we try to avoid a model that make us lose the chemical information. So if I take the example of super vector machine that we are using here, if you use like a polynomial kernel, you will probably lose the chemical information there because you are like transforming too much the response of the data. But here we use a linear one. So we sacrifice a bit of the accuracy of the model because we wanted to keep the chemical information there. And when we had these significant features identified from the model and we saw that it was working well, we started the identification process. I would say the validation of the identification process. And as you see on the graph here, all node compounds are identified. I have some family of compounds that are italicized. It's just that I know because of my GC-GC separation that they are alkylated hydrocarbons. But we have so many isomers that are possible there that I cannot be sure of what is the identity of the compounds. But in the compounds that we validate the identification with the standard, which was really interesting is the fact that it's not newcomers from us. So here it's lung transplant patient. I also work with asthma and COPD or sclerodermic patient. And again, this is the same compounds. A couple of hydrocarbons, but mostly non-anal, which like we try to identify in all the study that we are doing about inflammation. So it's really one of our top targets. So the second study that I want to show you, it's the effort that we are doing to try to have an in vitro model of lung inflammations, more specifically asthma, to be able to generate a larger volume of sample to allow us to really have a multi-omics investigation on the sample. So basically, it's really the beginning of our investigation there that I'm presenting today. So we start with something that we know, A549. So it's epithelial lung cell line that is commercially available, immortalized. So we know that it grows well and that we can control the culture condition. And what we decide to do is to generate oxidative stress. We are chemists, so we use a well-known way to generate oxidative stress using hydrogen peroxide. But we also use a biological stress by implementing neutrophilic incubation into our cell. So we were really mimicking what's happening in the lung when you have asthma exacerbation and you have like neutrophilic or eosinophilic cell recruitment in the lung. So we spent long meetings trying to design the study just because we needed so many controls. So if you look over the 10 group of compounds that sample that we have here, 6 of them are controlled. So we had the medium control and the medium spike with all the stress agents. So the hydrogen peroxide, the sputum containing inflammatory cell, LC sputum from people not suffering from any chronic inflammation, and PBS just to mimic spiking of something that has no effect. And the same with the cell. So we had this huge sample size, even if the really oxidative stress simulation was a really small part of it. And it's generally the case in metabolomics. And when you go in vitro, that's the goal, is to be able to have all this control to make sure that we can say with confidence what we observe on the data. So because we work with a small volume, we were allowed to work in small well for the development. So the first development was just to see how we can stress the cell without killing them. That seems obvious, but if you take the concentration used for spiking hydrogen peroxide from the literature, you have everything from high concentration to low concentration. So we had to see by ourselves what was working for us. So, and I will come back to the previous slide after. And the way that we did that is to check viability. So we were checking which concentration was killing the cell and which concentration was allowing the cell to grow normally, but generating some oxidation. And we found out that 60 minutes was a good time with 0.1 millimolar concentration. And if we look to the VOC profile on the PCA, you can really clearly see what's happening with the cell viability. You have in green, the control, so just the cell by themselves. In blue is the cell with a high concentration of hydrogen peroxide, so conducting to apoptosis. And after we have the oxidation. And if you have 0.1 or 1 millimolar, you see that you are basically in the same composition of the VOC composition. So we decided to go with the lower concentration just to make sure that we reduce the effect of spiking there. So if I go back to this slide, after optimizing this condition, we really took advantage of the study design. So we had a sample to control pair comparison to make sure that we can smooth out all the background. And in that type of culture condition, we have a lot of background to be able after to make some simple ANOVA approach on cell containing compounds. So it's really the cell minus all the control and the matching control that allow us to do the different investigation. So if we look to the chemical family that came after all this filtering, we see that it's again the same guys that we saw before. If you remember the graph that Jeff shown you, it's mostly hydrocarbons, alcohol, aromatic compounds, ketone, and aldehyde. So we really were able to generate the oxidative stress compound that we see usually in breast. So we are quite happy about that. So we are going towards these oxidative stress signatures. So after we look to for me, the most interesting part of the study was to use biological stress. So really trying to mimic what's happening in the lung in vitro. And the first thing that we did is to check also the viability. And what we see in our data is this over proliferation of the cell. So the cell were growing better with inflammatory sputum than with only medium. And it's something that clinicians are seeing also in the lung. So you have a over proliferation of the cell in the alveoli. So we were able to mimic also that behavior. So there is some growth mediator in the inflammatory sputum that promote the cell growth. And when you use sputum, so again, the same expectoration, but from a healthy individual, you don't have this growth. So it's not just that we are, by putting sputum, kind of bringing more cell, more nutriment to the cell that make them grow better. It's just the inflammatory markers that promote this overgrowth. So now we are working on the better characterization of this sputum to try to understand which are the mediator of this proliferation. And again, because of the kind of straightforward, even if complex design, we were able to really like investigate the chemistry behind all the observation that we did. And again, like you find the same people there. So we had the non-anal coming back, so he's only overexpressed in the cell with the inflammatory sputum. So not with the hydrogen peroxide, not with the healthy sputum. So again, a really good candidate to go deeper in the molecular understanding of inflammation process in the lung. So to conclude, so for me, lung fluids VOC analysis offer valuable insight on the lung inflammation. And that can be real lung fluids or lung fluids incorporated in an in vitro model, but that's really a good way for us to understand what's happening on the molecular level and the chemistry of the lung following inflammation. In vitro inflammation modeling is a key player to implement multi-omics. So we use only 500 microliter of the media. So when we have done that analysis, we still have the cell pellet that we can lease, analyzed by GC for small metabolite, analyzed by MALDI or LCMS for proteomics or lipidomics analysis. So that's really for us opening the door of something that will be really big in terms of understanding the molecular characterization there. Volatile metabolomic had a seat on the table for multi-omic screening. So for lung, the lung, it's kind of where everything go to the gas phase. So for us, it makes sense to study the small molecule and what is released there. And pushing forward breath analysis, we need to really have this like volatolomics approach on the sample. And of course, like again, like stressing the message that we already shared with you, it's like we need to optimize and validate everything. So even the processing. So now it's really, I think, in GC, but even if LCMS, it's ahead of us on that field, we need to catch up and have like more clear SOP for metabolomics research there. So I hope you were interested about our research. I will be happy to take any question. Our team will be in Valencia, so I hope to see a lot of you over there. And if you want to know more about the techniques, we are hosting a workshop in Liège about multidimensional chromatography, so multidimensional GC, but also LC. And it's a free event. There is hundreds of people attending. It's really a place to discuss and learn about the techniques. So if you are interested, just check the webpage and don't hesitate to join us. Thank you for your attention, and I will be happy to answer any question.
Thank you, Pierre, and thank you, Jeff, once again for your great presentations and for sharing your insights around gas chromatography, mass spectrometry, as well as the different models that you, Pierre, generated to analyze these data sets. So we have a few questions in the question box. So the first one is for Jeff. How did you perform the ROC test in the asthma example with the one response variable at a time?
Oh, can you repeat the question? Sorry, I had some issues.
How did you perform a the ROC test in the asthma example with the one response variable at a time?
I'm sorry. Can you hear me good? Because I do not hear you good. Can you
Yeah, I maybe I can step in when Jeff is checking the sound about so the question was like, oh, we can perform the ROC curve test with one variable at the time. So that was so that depends. So they are not only one variable at the time. So if I take the VOC for eosinophilic asthma, it's combining the answer of three volatile using random forest classification. We obtain a probability of classification, and that's what is plotted on the ROC curve analysis. And for the other one, so that was the blood cell count. So that's just a basic ROC plot trying to find what would be the best cutoff on the percentage of eosinophilic cell in the blood. And for the FeNO is the same. So FeNO, there is a background of a lot of research to know what is the threshold. I think the most common threshold is 41 ppm. So we try to see if we use this type of threshold and different type of threshold from the ATS and the ERS, we were matching that.
Thanks, Pierre.
Okay, thanks a lot. So the next question could be answered for both of you. So he wanted to ask how reproducibility and good sampling on biological matrix of volatile compounds can be checked.
I don't see Jeff anymore, so I think I will jump in on this one. So that's the challenge, to be honest, and that's why there is the peppermint experiment. It's because when you do VOC sampling from breath, you don't have anything to rely on. There is no certified reference material. There is nothing that we can do about the control of the sampling. So you need to rely on the staff training and the protocol that you set up, and having some breath experiment that you control, like the peppermint. You eat a peppermint pills, and after you have to see the peppermint metabolites. When we work with BAL or cell, we just generate our own QC. So we basically do pool QC approach, and we use that to monitor, and we use that for the sampling method development. So when we develop our SPME approaches, we compare the different like fiber available on the market, the different parameter of sampling, like the temperature of incubation, the time of incubation, the time of desorption on this pool QC. So when you have this sample, you can do a design of experiment and make sure that you are having a comprehensive picture. I would say that you have an exhaustive picture, because every time you will choose a type of fiber, a type of bag, a type of TD tubes, you will implement some selectivity, but I don't think there is anything that is really like exhaustive in terms of sampling. We try to be like as close as possible, but of course there is some part that we are missing.
Thanks, Pierre. The next one is also for you. Why do you do a 50-50 training testing?
Yeah, that was part of the optimization. So basically, because of the low population, so we had only 40 patients. If we wanted to, and we had unbalanced classes because we had way more lower PGD grade than high PGD grade, and that's good. That means that less people are sick, but that also means that to have enough PGD3 in both sets, we needed to go to 50-50 split. So it's something that we see more. So a lot of people are going for 70-30, 1/3, 2/3, but that's kind of like general guidelines that we are used to use, but there is no exact reason that. So for me, the most important is to try to make sure that you cover the distribution of your different class in both sets. So yeah, 50-50, it's like not the best, but that was the only solution to split the data.
Okay, thanks. So the next one is also for you. So the empty dot in PGD3, was it a false negative patient based on the clinical assessment?
Yeah, that's what we will never know. So they say that basically they have to make a decision because you have to put someone in a category. So they say that on the inflammation level, they could be related to PGD3, but there is other factor like infection that we don't control. So the classification is done for patient management. So patient management include inflammation management, but not only. So for us, it was a misclassification, but on the clinical aspect, this is much more complex than that. For us, where we are now with that study, we are just happy to see that we have a correlation between the classification probability and the grading system used in the clinic.
Thanks, Pierre. The next one is for either of you. Which software would you recommend for analyzing GC-TOFMS data?
I think I understood the question. So I'm going to switch off my camera because I realize that when my camera is off, I have a much better sound. So excuse me for the image, but can you hear me well?
Yes.
Yes, we can hear you.
Yeah, so when you do GC times GC, you have a few options indeed for the software that you can use. And different software have, I would say, different advantages and drawbacks. The major one on the market are if you use LICO instrumentation, LICO is one of the mass spec provider. Chromatoph has been used and is used by many groups. GC Image also from Zoex Corporation is also a very well-known software. Different provider of GC instrumentation also offers software. Some side companies also offer softwares, but they are, I would say, a bit less used. Sepsolve is also offering a very nice software nowadays. But I would say the first, they are expensive also. That's another point to consider. But basically the choice of the software might also be linked to what you want to do. Which part of the data treatment or the statistical treatment or the pre-treatment, how much of this do you want that software to do for you? Do you want to externalize part of the data processing or not? So as I said, I cannot tell you, oh, this is the best software, because it really depends on what you really want to do. But I would say if you look to the literature, most of the users either use Chromatoph or GC Image for data processing. But again, there are side softwares which are really nice as well. So there is a few companies nowadays that offer also solutions. So I would say it's a really it's good to speak with users to users that do the same thing or similar thing that you want to do, to see which software they prefer and to make your own opinion. But it's more choices nowadays than it was 10 years ago. That's the good news.
Yeah, and if I can add to that, we have all these commercial solutions that are the most efficient way, but there is also some open source solution that have been developed and are still under development. So there is the RGC-GC package that is available. So I would say they are not for beginners, because you need to understand really well the way the processing is working and the data are generated to be able to use them. But if there is people in the audience doing bioinformatic tool development and that are interested to work on that topic, please drop me an email. I will jump on that and we can have a call next week, no problem.
Thanks a lot, both of you. So the next question says, have you tried different polymer captures other than PDMS, CAR, DVB? If yes, any thoughts on the best capture?
Yeah, so we have a paper on SPME method optimization where we basically compare everything that was on the market. So we use a PDMS only, all type of combination of the three polymer that we are using, the way that they are coating, the thickness of the polymer. So that was investigated. To be honest, there is no huge difference. So you can see that some chemical family are better trapped on one polymer or another one. So I would say use like pick one, use it properly, and monitor it properly. That's the best way to do that. And after, of course, there is slight difference, but it's not as big as we could expect.
Yeah, maybe a comment on that. You might also consider with the type of sample, the quantity of water that your sample is going to be having. I mean, if you consider a breast sample with, let's say, low level of humidity, or if you consider the headspace of serum sample, the level of water might be a bit different. So some of those adsorbents might behave a bit differently, so might make your life a bit easier by trapping less water, for example. But that's not a huge difference. But if you have to make a choice, that could be a parameter to consider.
Thank you both. That's the next question was actually is the same, because I had the same question as well. Have you looked at using stable isotopes in the sampling? I mean, especially in your in vitro studies, Pierre, like if you use carbon 14, for example, and then like trace that stable isotope all the way to the end to see whether you can pick that up as a marker.
Yeah, the answer is no, but this is exactly what we want to do, and I'm happy to see that people are thinking the same way that we do. So when we say that we want to identify the origin of compounds like the non-anal, this is exactly what we are developing with our in vitro model. So we have some hypothesis of the origin of this compound. So now we would like to have the precursor or potential precursor of non-anal synthesized in C13, spike them in the cell matrix, and see if we can like see an increase of this label non-anal or other compounds in the VOC part. But that's exactly where we are going now.
Thanks. So I think here we have the last question. So if I have only one GC time of flight, what column do you recommend to use, or use the same XI 624 CLMS?
If you have only a 1D GC, I would say like for me, I would still recommend, if you have to use only one, to use something classic, like a 5% methyl, a 5% phenyl, 95% methyl siloxane, for the only reason that will allow you to use retention indices that are available in the NIST libraries. So that gives you an extra dimension of identification. And when you do untargeted research, this is really valuable. So sometimes it's better to lose a potential biomarker because you have a coelution, but the one that you separate, you know what they are, or you have a really good idea of what they are.
Thanks, Pierre. We actually have one more question. Do you have a reference material for urine studies that is commercially available, like the one that you have for plasma?
Oh, that I don't know, because I've never worked with urine. Jeff, maybe you have some experience with urine sample?
No, I'm trying to remember if something exists. I don't know. But quickly checking the NIST, website should help. But I'm not quite sure actually. But no, I don't remember any, at least. But it might have recently been produced. But I don't know. I don't know.
And one more general question: why are you using a PCA when you have 4 different groups rather than a PLSDA to extract the most important metabolites among the groups?
So for the in vitro study, we use PCA only for the visualization. So the feature selection is done by ANOVA, because we have really specific questions that we want to ask to the data. And for me, I don't want to use PLSDA that is supervised when PCA is providing me the information that I need. So I know that you have less risk of overfitting using PCA. So when PCA is working, I usually don't go to more complicated way to visualize my data.
So another question, when you work with breath samples, do you have any possibilities to take several aliquots from one sample, or do you only have one chance to analyze the sample?
That's a really good question. So you have two ways to do that. So you have, if you do as we do with sampling back, what you have to do is to take a really big bag. So we take 5 liter, and with 5 liter we can do 2 injections. So we inject a fraction, and after we can inject a second fraction, because we empty the bag on the tubes. We inject only 10% on the GC, and after the 90%, if you inject a good proportion of that, you can have like a reproducible injection. And if you use direct sample like the Reciva, that is a commercial device, you can have up to 4 replicates of breath sampling. So you need to, again, to plan it in advance, to sample enough volume to make sure that you have replicates, but there is a way to do it.
Perfect, thank you. I think that's all for today. I would like to thank you once again for giving us these really nice presentations. And I would also like to thank everyone who attended this webinar. And yeah, see you all very soon in Valencia. Perfect. I just stopped the recording now. Right. Thank you, Jeff. Thank you for the talk, and thank you for recommending Pierre. It was an excellent talk, and I really hope to meet you both in person very soon.
Yeah, I will not be in Valencia myself because I'm attending another meeting, but Pierre-Hugues and some of my other students will be there. So yeah, definitely that would be nice. And congratulations for the organization.
Perfect. Thank you so much.
Thanks a lot.
See you guys.
Thanks, Alvaro.
Thanks, Avelina.
Thank you for your help.
Both of you. See you in Valencia soon.
Bye. Bye, everyone.